Okay, I'm sorry for the delay. I'm going to make up for this time. Now, we are going to speak on, tell you our experience on endovascular management of massive pulmonary AV fistulas, which we have a series of 28 cases now. Uh, just to give you a background, 2 to 3, the incidence is 2 to 3 per 100,000 population. 80% of these are congenital, some are acquired, and they have a high association with hereditary hemorrhagic telangiectasia. They could be solitary, multiple, or diffuse, and anatomically they could be central, that means the central part of pulmonary artery to left atrium fistula, or could be peripheral, pulmonary artery to pulmonary vein fistula. Now, these are the types, various types, both the central, which you see on the left lower quadrant is the right pulmonary artery to the left atrium pulmonary AV fistula, and the ones on the top are the peripheral AV fistulas, and the one on the right side is again a peripheral pulmonary AV fistula with mitral valve stenosis. Now, most of them, not most, at least 50% of them are accidentally detected. They have no symptoms except for a cyanosis, which is seen or picked up by a doctor when they come for some other problem. Some of them present with dyspnea on exertion, and some of them present with neurological symptoms, mainly migraine, vertigo, transient ischemic attacks, paresis, numbness, syncope, confusion, and cerebral abscess. And some of them do die with fatal hemoptysis and hemothorax. A diagnosis is based on clinical suspicion. If you have a cyanosis with a normal echocardiogram, you start suspecting a normal 2D echocardiogram, you start suspecting pulmonary AV fistula. And if you do a air contrast echocardiography, you can almost certainly diagnose pulmonary AV fistulas. A chest X-ray abnormality is seen in more than 90% of the patients, and a CT scan, MRI, or radionuclide lung scan can also pick up, but the angiography remains the gold standard for pulmonary AV fistulas. Now, historically, pneumonectomy, lobectomy, or local excision and ligation of pulmonary artery were the treatment of choice, but currently endovascular management is the treatment of choice. And basically, we have two ways we can treat this. One is coil embolization, which could be bioptome assisted, or an Implanter ASD device or an Implanter plug, which could be of either generation, first, second, or third, are good ways to treat this and close these AV fistulas. The case selection depends on multiple, the case selection depends whether they are solitary or multiple, and we have to remember that multiple diffuse arteriovenous fistulas cannot be occluded. We can occlude some of them, like you saw in Dr. Panja's case. And therefore, angiography in many views is necessary to clearly identify the point of communication. A clear definition of native pulmonary artery supply is very important. We usually introduce a long sheath first and take a Berman's catheter, which is advanced via this long sheath, and the balloon is inflated, and then the catheter flows in the direction of the flow. And the large flow across the fistula guides the balloon to the branch which supplies the AV fistula. Then we do a selective angiogram, localize the point of communication, and then try to seal it. The distal sheath is positioned in the vessel which supplies the fistula, so we track the sheath over this balloon. Then we deliver coil, which could be single or multiple, using bioptome assistance, or a vascular plug, depending on the size of the pulmonary artery. Normally, we size the size of the vascular plug to be at least 1.5 times the size of the diameter of the vessel. We have to ensure that there is a complete or near complete occlusion when we are delivering this. And we have to meticulously check for additional sites of fistula, which could be small in an initial angiogram, but may appear bigger on a subsequent angiogram. And for a clinical success, the saturation should improve or become almost normal at the table itself. Now, this is a catheter closure of the pulmonary artery to LA communication, which is a very rare abnormality. It clinically manifests similar to pulmonary arteriovenous fistula. This patient presented with cyanosis and hypoxia, and there was a communication between the right pulmonary artery and the left atrium. And this was first we sized the communication with the balloon, after we had this loop, and then we put a long sheath, and then after the long sheath, we close this with an atrial septal implanter device. So it was an ASD occluder which we put across, and we closed this pulmonary artery to LA fistula. Now this is another interesting case which I think we presented as a live case when we were doing APVIC-V in Apollo Hospital. This is directly from the cath lab. Yeah, this is an interesting patient which came just a night before the second APVIC. The patient was diagnosed as a case of congenital heart disease because the patient was deeply cyanosed, had clubbing in fingers, and if you see on the right side, the saturation was 71%. So the patient came from Kashmir, and most of the people thought he's a congenital heart disease. But when we did an echo, we found that the patient had rheumatic mitral stenosis, and even you can see it on the left lower panel, and the CT revealed a large pulmonary AV fistula with mitral stenosis. So this is one of the very rare cases, I think the only case which we have seen in the literature, who had a rheumatic mitral stenosis and a large pulmonary AV fistula masquerading congenital cyanotic heart disease. So this is what we did. We got a Berman's catheter, and we selected the vessel, which was the left lower pulmonary artery. Then we went down with a sheath, and we could localize the entry point. After that, this is the Implanter 3 vascular occluder, which we positioned at a place where we could sort of close both the entry points in the left, both the branches of the left lower pulmonary artery. And after we were secure, we were sure that this is the right place, we sort of detached the cable and did an angiogram subsequently, and we closed this fistula. There was another small one which we left, and the saturation improved on the table itself. We got a 92% saturation. This is another case which I did with Dr. Panja in Calcutta, where again as a live case, where we used multiple Implanter 3 vascular plugs to occlude the fistulas. This is the first one being released. So in all, we have done 28 cases up till now with a mean age of 26 years. And of these, 3 were central and 25 were peripheral, so which are more common. We coil embolized 8 pulmonary AV fistulas. We did a device closure in 23. And in 3 patients, we used additional coils, coils plus implanter device. We achieved technical success in all the patients. We had to repeat procedures because we left some of the pulmonary AV fistulas which actually enlarged later on, like in the case which was shown in the Ironman session in 5 patients, and we have to redo the procedure. The saturations improved, mean saturation were about 70%, improved to 95% plus in all the patients. Thank you very much.